Hello everyone, I'm Genesis Salvador and today I'm going to tell you a little about immunotherapy in renal cell carcinoma and Ribavirin for chronic hepatitis E virus infection in transplant recipients. So, the first topic is immunotherapy in renal cell carcinoma. Definition: what is renal cell cancer? Renal cell cancer is also called hypernephroma, final adenocarcinoma, or renal or kidney cancer. It's the most common kind of kidney cancer found in adults. RCC occurs when cancer cells start growing uncontrollably in the lining of the tubule of the kidney. RCC is a fast-growing cancer and often spread to the lungs and surrounding organs.
Renal cell carcinoma is the most common type of kidney cancer in adults. It accounts for approximately 3% of adult cancers, and the incidence has risen steadily by about 2 to 4% each year in the past few decades. It is effectively a collection of different types of tumors, each derived from the various parts of the kidney cell and displaying salient genetic characteristics, histological features, and, to some extent, clinical picture. When it metastasizes, it has the tendency to spread to the lymph nodes, lungs, liver, adrenal glands, brain, or bones. While the exact cause of renal cell carcinoma is unknown, there are risk factors that increase the chance of developing it, such as smoking, high blood pressure, family history of kidney cancer, and obesity. The chance of developing renal cell carcinoma increases with the age, and males have double the chance of having it compared to females. In a lot of patients, this cancer may not produce any symptoms for most of its course. Only about 10% of patients present with the classic triad of flank pain, blood in the urine, and lump in the abdomen. Other signs and symptoms may include unexplained weight loss, fever, night sweats, weakness, fatigue, nausea, and high blood pressure. Renal cell carcinoma is associated with a number of paraneoplastic syndromes, which are conditions caused by either the tumor hormones produced by the tumor or by the body's attack on the tumor. In about 20% of these patients, paraneoplastic syndromes are present, such as high blood calcium levels, high red blood cell count, high platelet count, and deposition of amyloid protein in one or more organ systems. To diagnose renal cell carcinoma, signs and symptoms and past medical history play significant roles. Based on the symptoms and signs, a range of biochemical tests are considered to provide sufficient diagnostic clues. Kidney imaging is vital, mainly consisting of ultrasound, CT scanning, and MRI scanning of the kidneys. Biopsy of the suspected kidney mass helps confirmation of the diagnosis. To evaluate the extent of cancer spread, PET scanning is a standard imaging modality. The therapeutic approach to renal cell carcinoma is guided by the stage or degree of tumor spread, pre-existing medical conditions, and overall health and age of the person. The principal treatment options for renal cell carcinoma consist of surgery, immunotherapy, and targeted therapy. Partial or complete removal of the affected kidney is the standard treatment for localized renal cell carcinoma. Immunotherapy, or biologic therapy, works by boosting the body's immune system to help destroy cancer cells. Cytokines are the artificially engineered versions of natural proteins that activate the immune system, and the ones most often to treat kidney cancer are interleukin-2 and interferon alpha. The targeted therapy works by blocking growth of the new blood vessels that nourish cancer cells or downplaying important proteins in cancer cells that help them grow, or both. Clinical response rates with chemotherapy, either monoagent or combination, are usually less than 15%. Renal cell carcinoma is not very sensitive to radiation, and radiation therapy is more often used to palliate or ease cancer symptoms in case of cancer spread. For more information about a list of expert doctors, hospitals, and ongoing clinical trials, please visit www.expertdocs.com.
Application in medicine. Patients with advanced or metastatic cancer are treated systemic therapy that includes targeted therapy and immunotherapy. Kidney cancers tend to be resistant to both chemotherapy and radiation therapy. Immunotherapy in the form of immune-stimulating chemicals called cytokines were a common first-line therapy for advanced kidney cancer.
Looking into the future, there's a study called Cosmic 313, and the control arm is ipilimumab and nivolumab. Many other people, including myself, I guess, have done a lot of work on the development of VEGF targeted therapies. And it's been really successful, but I think we've moved on now from VEGF targeted therapy as monotherapy in frontline renal cancer. And I think we've now moved to a backbone of immune checkpoint inhibition, and Cosmic 313 is nivolumab, ipilimumab as the control arm, against ipi-nivo plus cabozantinib. I hope it's going to be positive because it's bringing everything together and making sure that there aren't any patients who aren't getting the 3 active targets that we know are really important in this disease.
Pros and cons. Pros. The goal of immunotherapy are to help your immune system to recognize cancer cells as threats, boost its response to the cells, and stop tumors from hiding. Cons. They can cause side effects such as tiredness, diarrhea, and high blood pressure. Issue applied in Ecuador. Renal cancer constitutes 2 or 3% of all malignant pathologies. Of the clear cell carcinoma correspond to approximately 85% because the high topological type is resistant to chemotherapy. New molecules are used for treatment worldwide called targeted therapy with significant results of progression-free survival and overall survival.
Our immune cells protect us from harm, patrolling our blood in search of potential problems, and travelling to sites of infection or damage. These cells need to spot the difference between healthy and unhealthy tissues. For example, when our cells are infected with a virus, they need to be destroyed. Infected cells display different molecules on their surface from healthy cells, indicating they're damaged. Immune cells can recognize these signs of disease and pass on instructions that tell the infected cell to self-destruct. But when it comes to cancer, the situation is a lot more complicated. For a tumour to grow, it needs to avoid detection. One way tumours can do this is to produce molecules that can trick the immune system. One of these is called PD-L1. It interacts with a molecule on the immune cell, telling it to ignore the cancer. But researchers have now developed drugs to interfere with this process, allowing the immune system to attack the cancer. And for some cancers, these new immunotherapies look set to change the way the disease is treated.
Conclusion. Novel combination strategies are being explored to deepen and extend response achieved with immune checkpoint inhibitor-based therapy.
Immunotherapy has offered hope for curing cancer for over 100 years now, but now it is delivering on this promise, and the reason behind that is new strategy, and that is immunotherapy. Immunotherapy is a new tool to fight cancer. How does immunotherapy work? It activates body's own immune system to fight cancer. At Max Cancer Center, we are dedicated to the research in different fields, and we have treated over 200 patients with immunotherapy. And immunotherapy is especially in the lung cancer. And now, with the advent of Immunotherapy, with the advent of immuno-oncology, we see more and more patients survive. Immunotherapy works only in 40 to 60% of patients. It does not work for everybody. At Max Institute of Cancer, Shalimar Bagh, we are looking at different approaches how to augment the effect of immunotherapy. And so far what we have tried, we have combined immunotherapy, radiation therapy, and we have seen good results.
So, the second topic is Ribavirin for chronic hepatitis E virus infection in transplant recipients. Definition: hepatitis E is a liver disease caused by hepatitis A virus. The virus has at least 4 different types: genotypes 2, 1, 3, and 4. Genotypes 1 and 2 have been found only in humans. Genotypes 3 and 4 circulate in several animals without causing any disease and occasionally infect humans.
Hepatitis E is RNA virus, spread by the fecal-oral route. Incubation period 3 to 8 weeks. Common in Central and Southeast Asia, North and West Africa, and in Mexico. Causes a similar disease to hepatitis A, but carries a significant mortality, about 20% during pregnancy. In general, hepatitis E is a self-limiting viral infection followed by recovery. Prolonged viremia or fecal shedding are unusual. In acute infection, IgM antibodies to hepatitis E virus are positive. Does not usually cause chronic disease. A vaccine is currently in development, but is not yet in widespread use. Thank you for watching. For more videos, subscribe to our channel.
Application in medicine. Currently, there are not specific drugs approved for hepatitis A virus infection, but Ribavirin, the drug of choice, is used for off-label treatment.
Hello, I'm Graham Foster, and I'm the lead author on a paper looking at tolaprovir in patients with genotype 2 and genotype 3 hepatitis C. This is a large, multi-centre, multinational study trying to work out whether tolaprovir is a useful drug for patients with genotype 2 and genotype 3 hepatitis C infection. Now we know that for patients with genotype 1 hepatitis C, current treatments are rather poor, and we know that protease inhibitors such as tolaprovir significantly increase the response rates. We take a patient with genotype 1 hepatitis C and we treat them with tolaprovir. Within a very few days, the virus has come down by a very large amount. And we know that if we add tolaprovir to pegylated interferon and ribavirin, the response rates are dramatically increased. The question we're trying to address is whether or not the same thing holds true for patients with genotype 2 and genotype 3 hepatitis C. To study this, we took a small cohort of patients with genotype 2 and 3 hepatitis C, and we randomly assigned them to one of 3 treatment groups. Some patients got tolaprovir monotherapy, tolaprovir on its own for 2 weeks. Other patients got pegylated interferon and ribavirin, and a final group got peg interferon, ribavirin, and tolaprovir. Everyone, even those on tolaprovir monotherapy, eventually went on to receive a full course of pegylated interferon and ribavirin. What we found was rather surprising. For patients with genotype 2 hepatitis C, it was very clear that tolaprovir was helpful. Giving tolaprovir on its own led to a very rapid, very large reduction in hepatitis C replication. And when we added this to peg interferon and ribavirin, the reduction in the virus was even greater. So we think tolaprovir works for genotype 2 hepatitis C. For genotype 3, the results were rather disappointing. The mean viral load reduction was only about half a log, so we think that giving tolaprovir to genotype 3 patients has relatively little benefit. If you look at the paper, you can see that out of the 8 patients with genotype 3, only 3 patients had anything like a significant reduction in their viral load, so we now believe that tolaprovir really doesn't help patients with genotype 3 hepatitis C. So the take-home message from this study is that for patients with genotype 2 hepatitis C, we think tolaprovir might have a useful clinical role and will now need further studies to optimise and see if we can use this drug in clinical practice. For genotype 3, I'm afraid the results are rather disappointing, and we would recommend that patients with genotype 3 hepatitis C do not go on to receive tolaprovir therapy, perhaps outside sophisticated clinical trials. I should point out, of course, that there are a number of different protease inhibitors now being developed. There are protease inhibitors on the market. Boceprevir and tolaprovir are widely available in the United States. There are other protease inhibitors in development. What we don't know is whether the results of this study cross over to other protease inhibitors or whether they're restricted to tolaprovir. Thanks for listening.
Pros and cons. Pros. Ribavirin is a general antiviral that inhibits replication of many RNA and DNA viruses. It has long been used to treat hepatitis C, along with pegylated interferon alpha and now several active anti-HCV agents. Cons. Ribavirin is a safe treatment option for hepatitis E virus infection. However, the optimal dose of ribavirin for the treatment of chronic hepatitis E remains to be determined as treatment failure may occur. Issue update. In Ecuador, every year there are an estimated 20 million hepatitis E virus infections worldwide, leading to an estimated 3.3 million symptomatic cases of hepatitis E virus.
Our lab studies hepatitis B and E viruses, which cause about 300 million infections worldwide and kill almost 1 million people annually. Neither one has a cure. We have developed new screening systems to identify new drugs to cure these viruses. Both hepatitis B and E viruses affect the liver, but they are very different viruses. Hepatitis B virus is transmitted through the blood and other bodily fluids. It enters liver cells where it hides in the nucleus. We try to find drugs that can kill this virus without causing harm to the patient. Hepatitis E virus infects people through contaminated pork meat and water. We try to find molecules that can stop the virus from making copies of its genome. Our screening systems are faster and safer than existing platforms. Our systems are high throughput, meaning that we can screen millions of compounds within a short period of time. We modified both viruses so they are safe and robust for screening. The screening system closely mimics the situation in patients with chronic hepatitis infections. With these screens, we hope to provide cures for viruses that cause serious global health problems.
Conclusion. This retrospective multicenter study showed that ribavirin as a monotherapy may be effective in the treatment of chronic hepatitis E virus infection. A 3-month course seemed to be an appropriate duration of therapy for most patients.
There are various causes of hepatitis, but today we are looking at an infectious one called hepatitis E and how it can affect you. Did you know that your liver is the heaviest organ in your body? It does several important jobs, including cleaning your blood and producing a liquid called bile, which helps digest your food. It's important to keep your liver healthy, which is why we want to avoid hepatitis, a term that is used to describe inflammation of the liver. The hepatitis E virus, known as HEV for short, can cause infection through several routes. One of these is by eating undercooked pork, wild boar meat, and pork products. Although HEV can be present in animals such as pigs, it does not normally live in real. When it infects humans, the symptoms of HEV infection are usually mild and clear up in a few weeks. However, the disease can, in rare cases, cause serious health problems and even death. The good news is that you can reduce the risk of HEV by following a few simple steps. When cooking whole cuts of pork, wild boar meat, pork products and offals such as kidneys, make sure that the meat is thoroughly cooked and not pink when you cut into the thickest part, that it is steaming hot all the way through and any juices run clear. Practicing good hygiene is also important. Wash your hands thoroughly before preparing or eating food and after using the toilet. Always remember to clean surfaces properly and chill food at the correct temperature. Handle it carefully so it doesn't cross-contaminate other foods or surfaces. So there you have it. FSA explains hepatitis E. To find out more, visit food.gov.uk.